Hello, I'm Dr. Andrew Matisoff from Children's National Hospital in Washington, D.C. Today I'll be talking about preoperative evaluation and postoperative pain management in pediatric anesthesia. I have no disclosures. So what are the goals of a preoperative evaluation? Well, one, we want to estimate anesthetic and surgical risk such that we can optimize the patient to minimize perioperative adverse events. One such example of this is we commonly pre-admit our sickle cell patients and give them exchange transfusions to minimize the risk of a postoperative sickle cell crisis. We also want to develop an anesthetic plan and a plan for postoperative pain management and determine the appropriate disposition for such patients to recover. So is the patient appropriate to go home the same day as surgery, or do they need to recover in a hospital setting or even in an ICU postoperatively? These should all be determined during the preoperative evaluation. What is the anesthetic risk in children? Well, there were some studies done about 10 to 15 years ago looking at perioperative risk in children, and compared to adults, the incidence of cardiac arrest related to anesthesia in children is about 1 in 10,000, which is about 10 to 20-fold higher than adults. They found that the highest risk were in children less than 1 year of age and those with severe disease. One caveat to this is these studies were done about, like I said, 10 to 20 years ago, and a lot of the complications were related to medications. Well, many of these were looking at patients that had received halothane, which has strong myocardial depressant effects. Since halothane is rarely used these days and most patients receive Sevo and isoflurane, which have less intense myocardial depressant effects, that overall risk of medication side effects has probably come down. That being said, the risk of cardiac arrest related to heart and lung disease is probably increased due to the more complex patients being operated on. Which patients am I most worried about? So the ones I'm most worried about are neonates, those with a history of prematurity, those with genetic syndromes, and those with congenital heart disease, as well as those who have upper respiratory infections. Why do neonates such higher risk compared to older children? Well, for one, elective surgery is almost never done in neonates. So most of the time they're undergoing urgent or emergent surgery. In addition, they're most often having surgery on major organ systems such as cardiac surgery or thoracoabdominal surgery. In addition, many of these neonates often have severe underlying cardiac and lung disease. Small babies are at risk for temperature instability, which can then lead to increased risk of infection, problems with glucose metabolism, and wound healing. In addition, neonates have a much smaller blood volume, so even small losses in insensible fluid losses or in bleeding during surgery can cause hemodynamic changes. And then, as a whole, neonates tend to have a less robust immune system and are at risk for severe infections from milder infections, and that can spread to the central nervous system more easily. Moving on to congenital heart disease. Congenital heart disease patients probably are overall the highest risk patients that we take care of having surgery. Children with congenital heart disease having anesthesia probably have around a 1 to 1,000 chance, 1 out of 1,000 chance of having a perioperative cardiac arrest. And a recent study by Ferroni looked at children with cardiac disease having non-cardiac surgery, and they looked at the NSQIP database, and they found that children with severe congenital heart disease had up to an 8% 30-day mortality after non-cardiac surgery. Those with moderate congenital heart disease had about a 3 to 5% 30-day mortality. The cause of cardiac arrest in these children with congenital heart disease is multifactorial, but they're at risk for dysrhythmias. Those with Shunt-dependent lesions can develop hypoxia. Those who have, in addition, those with shunts or surgical shunts are at risk for clotting of these. And then patients that are dependent on a duct for circulation or a shunt for circulation are at risk for systemic and pulmonary imbalance, so where the blood can be shunted improperly to either the lungs or the systemic circulation at the expense of the other circulation, which can cause either hypoxia or low cardiac output and ischemia. Patients with congenital heart disease may have their risk minimized by having specialized care teams of anesthesiologists and postoperative care units, as well as cardiologists familiar with caring for such patients who care for them, though there is limited data to support this. But there is some evidence that having specialized teams to care for these children may minimize their risk because they can understand the diverse physiologic needs of these patients. Among those patients with congenital heart disease, which ones tend to give me the most concern? These are those with unrepaired congenital heart disease, those who are interval stage 1 or have had a Norwood or Sano, those with pulmonary hypertension, those with dilated cardiomyopathy, and those with coronary concerns. Among those who are interval stage 1, these patients often have a Blalock Taussig or a Sano shunt, and these patients not only have their blood flow balance between their pulmonary and systemic circulation, even small changes such as a little bit of oxygen can cause QP-QS imbalance, which can then affect how much blood flow they're getting to the systemic circulation, but they also frequently can clot off these shunts, which can cause acute hypoxia and is, without urgent intervention or ECMO, these patients a lot of times are at risk of death. Those with pulmonary hypertension, especially those with systemic or suprasystemic pulmonary hypertension, are also a very high risk for anesthesia and surgery. And those with suprasystemic pulmonary hypertension as well as severe RV dysfunction probably have, from what's been seen, about a 25% risk of cardiac arrest having anesthesia. Finally, patients with Williams syndrome, which you see this patient has, they have very cute children with specific facial features such as the upturned, the wide lips and the upturned nose. These children can have coronary issues as well as supravalvular aortic and pulmonary stenosis, and there's several documented cases of these children having sudden cardiac arrest just with induction of anesthesia. Patients with genetic syndromes, in addition to their medically complex children with multi-organ system involvement, can also present challenges for their airways. So a good portion of the children we do at the Children's Hospital have genetic syndromes, so you have to be familiar with their airway risk. So patients with Down syndrome, who we see in the bottom left corner, these patients can have upper airway obstruction due to their large tongue and are at risk for hypoxia and respiratory insufficiency with small doses of narcotics. In addition, we see a patient here, we see a patient with Hurler's syndrome or mucopolysaccharidosis. They can be extremely challenging to intubate. Another patient here has trisomy 18. This child can be difficult to intubate, and a lot of times it can get worse as they get older. And then many of our medically complex children end up developing subglottic stenosis because they've had, long stays in the neonatal intensive care unit, or they've had long intubation times after abdominal or cardiac surgery as a baby, and that they can develop scar tissue, which can then lead to subglottic stenosis. So even if these children have normal anatomy on the outside, once they've been intubated, once you are able to visualize the larynx, you may not be able to pass the breathing tube in such patients. Other patients I'm concerned about are those with an upper respiratory infection. So I'm going to give you my approach in such patients. traditionally we've been told that all patients with upper respiratory infections should be having, elective or semi-elective surgery should be delayed 4 to 6 weeks. We need to understand that a lot of these patients who present, and when they developed these algorithms, they were developed not for pediatric anesthesiologists working at tertiary or quaternary care hospitals, but they were developed for a lone anesthesiologist working in a surgical center where there's very minimal support. So a lot of the decision making needs to depend on the environment the children is being worked on and the experience of the anesthesiologist and the care team taking care of them. So where a child, with mild symptoms may still be at risk for problems if they're at a small surgical center where there's just one anesthesiologist and not a lot of help if he has postoperative respiratory problems, at a children's hospital where there's plenty of additional support nearby, that may not be an issue. So overall, I would say any child having urgent or emergent surgery should continue with their surgery despite their symptoms. Children with having elective surgery, what I typically do is I'll assess the patient. If they have a significant fever greater than 38 degrees Celsius, a productive cough, or I hear audible rales and bronchi on exam, then we'll have to have a discussion with the surgeon and the family. And in most cases, if the case is completely elective, we would delay the surgery for four weeks. If the child, if this surgery is something that, there's been a lot of, for instance, we've had to hold patients' medications or, arrange for, ICU beds after, then you have to have a discussion with the surgeon and the family and decide, is it worth proceeding with surgery, even though we understand that there may be a slightly increased risk of postoperative and perioperative respiratory events. So I would not be an absolutist in this. I think it's a team discussion. And in most cases, everyone on the team as well as the family can come to a satisfactory conclusion and do what's best for the child and the family. Final thing I'll say about preoperative workup is that in addition to looking at all these patient factors that we discussed, we also need to include the surgical risk. And Dr. Nasser from Boston Children's did a nice review where they looked at tons of data, and they incorporated not only patient factors but also surgical risks, and they use the CPT risk quartiles to estimate surgical risk, and things that they consider to be highest risk in surgical in risk quartile 4 were these surgeries that I'm showing below. Things like total splenectomy, tracheostomy, gastric bypass, intracranial surgery. And the reason these are, it may not be that the surgical procedure itself it may be because the types of patients that are having these surgeries have several comorbidities, are at high risk. But that being said, by incorporating the surgical risk into the overall risk and the type of surgery into the overall surgical risk, they were able to really nicely get some estimate of overall risk of perioperative morbidity and mortality. Now I'm going to move on to a quick review of postoperative pain management in pediatric anesthesia. So it wasn't long ago, all the way, not even back in the 1980s, where there was this idea being practiced that little babies didn't feel pain. And it was not uncommon for children to be anesthetized solely with a dose of pancuronium or muscle relaxant without any analgesia and minimal anesthetic agents being provided. But thankfully now we do know that babies do feel pain. And just to review, the pain is transmitted from the primary afferent neurons to the dorsal horn of the spinal cord, and then the descending inhibitory and other pathways from the brain can modulate these pain sensations. So babies, yes, they do feel pain, and they actually may experience more intense pain than older children due to less mature descending inhibitory pathways. And it's been shown that the stress response and the physiologic responses to pain in infants can not only cause them distress, but it also may worsen their medical conditions and can lead to comorbidities. So not only does it increase their metabolic demand, it can lead to poor wound healing. It can increase their risk of respiratory complications due to splinting and atelectasis, which can put them at risk for pneumonia. They can develop thrombotic complications, and they have probably worsened bowel function. So it is important to give appropriate pain management to all of our pediatric patients, not only intraoperatively, but postoperatively. In fact, in older children, not only do they have these physiologic changes from pain of increased oxygen consumption, worsened cardiac and respiratory and bowel function, and increased risk of thrombosis due to decreased mobilization, but they also suffer emotional and physical distress. And it's been shown that children can have sleep and behavioral changes up to 1 year after a surgery where they had significant postoperative pain. So how do we assess pain in pediatrics? Well, in the infants, we tend to use pain scales. So the most common ones used in infants are the NIPS nonverbal pain scale, as well as the CHEOP score, shown here below. In older children, we typically use the FLAC scale or the FACES. And these are all really good assessment pain scales that can be done by the bedside nurse or any team member to assess pain in different ages of children. I'm a big proponent in using multimodal pain management, and this not only starts with pharmacologic measures. This could include using child life to help calm children. In small babies, pacifiers, swaddling, and sugar water or sweeties on the pacifier can help manage pain in children for mildly painful procedures, as well as technology is very useful. Screens, virtual reality, all of these have been shown to minimize and really avoid the use of pharmacologic agents for mildly painful procedures. In addition, mild pain, the standard of all of our pain management should be using non-opioid agents. So acetaminophen, ibuprofen, ketorolac are very useful in managing pain and really should be the go-to for managing pain in most patients. And it's been shown that many procedures which have been done in the past using opioids are now just as effectively managed. The pain is just as effectively managed without opiates. These are things like tonsillectomy and even appendectomy. And as you can see here, they've shown that with a multi-institutional study, they were able to reduce their incidence of opioid administration from 18% to 4% without any worsening in patient satisfaction as well as pain scores. In addition to ibuprofen and acetaminophen and paracetamol, we have other agents such as dexmedetomidine, which is an alpha-2 agonist, which is also very effective for managing pain. That being said, while I try to avoid opiates if possible, many procedures still rely on opiates, and my overall strategy in using opiates is I try to avoid using short-acting opiates unless for very short-acting periods, and I try to get patients on longer-acting agents as soon as possible. So as soon as a patient can take PO, we try to get them on oral oxycodone and switch them to long-acting agents. But if they're still having pain, you should not be afraid to consider IV narcotics if needed. Finally, regional anesthesia is really grown over the last several years, and it should be considered in all patients. A caudal block is a relatively simple procedure with very low complications, and it can be performed by an experienced provider. For procedures under the umbilicus, it can be performed in a few minutes, so it really doesn't delay surgical time, and it comes with minimal risk. and peripheral and truncal nerve blocks have really expanded because of the use of ultrasound to target these specific nerve groups or fascial planes. And overall, even though there's limited data to support them, because the providers have become so good at targeting these nerves and minimizing the risk and complications, the risk has gone down so much that overall it's worthwhile to consider them for procedures. Finally, I just want to address some controversies in pain management. So first of all, ketorolac, a lot of hesitancy has led to its, hesitancy in its use because of concerns over bleeding or decreased bone healing. Thankfully, there's been meta-analyses as well as several studies, and all have failed to show significantly increased bleeding from using ketorolac, as well as decreased bone healing in surgeries such as spine surgeries. So I think it should be considered in many patients, and only in some cases should be held due to concerns about bone healing and bleeding. But in most patients, can be either ketorolac or other forms of NSAIDs can be used appropriately for pain management. The other controversy is the use of regional anesthesia and the concern that it masks compartment syndrome. But there's thankfully been several documented cases where compartment syndrome was still discovered despite a functioning nerve block. So I think as long as the team has good communication, you can still use regional anesthesia in many cases without being concerned about masking compartment syndrome. And just an overall thought, while opioids are necessary in many cases, they're still, probably lead to more opioids, and associated agents are probably associated with more pharmacologic complications than any other drug we do use all to put together. So any medication or technique which minimizes their use is beneficial. Thank you for your time, and I appreciate the opportunity to speak.